Hello, everyone, and welcome to today's show, where we're going to be talking about psychiatry and philosophy of psychiatry, or for a kind of tangential topic in philosophy of mind as well, for people who are interested in that. And I'm joined by a guest today, Dr. Awais Aftab. I hope I've not mispronounced your name, by the way.
That's good.
Okay, good. And you are a practicing psychiatrist, but also an assistant professor. Am I right? Is there anything else that is relevant to your background for people to know going into this conversation?
Yes, yeah, that's basically right. So I'm a full-time practicing psychiatrist. I work clinically with patients, and I'm a clinical assistant professor of psychiatry with Case Western Reserve University. So I work with psychiatry trainees who are doing psychiatry residency, and I also work with medical students.
So you write this Substack psychiatry at the margins, where you've put out like a bunch of really interesting articles that I think are also like quite accessible for people who are like interested in psychiatry generally or philosophy. And you've also got this book out recently too, about critical psychiatry, kind of exploring a bunch of topics in psychiatry in these kind of dialogue essays with other people as well. So I think that that's really interesting for anyone who's interested. But today, kind of going to do a tour through philosophy of psychiatry and psychiatry practice. So the first question, I guess, for people who don't have an idea is, what is psychiatry? And how does it differ from other disciplines like psychology? Obviously, it's a branch of medicine, but from like what people might think of in medicine or psychotherapy.
Yeah, and that's a useful question to start with for a lay audience. So psychiatry, as you mentioned, is a branch of medicine, and it's the branch of medicine that deals with mental disorders, with severe behavioral disturbances and behavioral difficulties that have been identified over time as conditions that could benefit from medical assessment and medical treatment. So they're generally called psychiatric disorders, mental disorders as well, and they're classified in these medical diagnostic manuals. In US, the DSM is the most common one, and many other parts of the world, ICD. Psychology, in contrast, is a kind of scientific discipline that is devoted to a scientific understanding of human behavior, human experiences, and various other subjective and cognitive aspects. Um, because it's a general scientific discipline, it studies all aspects of behavior and experiential aspects of it, and it's not just restricted to behavioral problems. And we have many branches of it, people doing all kinds of research. Some people interested in perception, for example, some people interested in cognitive psychology, some people interested in social psychology, moral psychology. It's a very wide domain. The branch of psychology that does deal with behavioral problems and behavioral disturbances is known as clinical psychology. And there is a fair bit of overlap between clinical psychology and psychiatry, because understandably both are dealing with disturbances of behavior. Um, the um, the difference kind of comes down to professional backgrounds, as well as the skill sets that are acquired and the kind of specialization that has developed between these disciplines over the years. So since psychiatrists are medical professionals, they are trained in diagnostic assessments, they are trained in medication management and prescription of medication. So any medication treatment that is required for mental disorder, psychiatrists are specialized in that. And then they also specialize in various forms of neurostimulation treatments. So things like transcranial magnetic stimulation, other interventional procedures such as intranasal sprays or infusions of certain medications, and things like electroconvulsive therapy for certain severe psychiatric kind of conditions. And psychiatrists also tend to get a certain minimum of psychotherapy training, but the extent to which they practice psychotherapy varies considerably from different regions as well as different practices. Versus clinical psychologists, they many of them specialize in diagnostic assessment as well. Some also specialize in neuropsychological testing or neurocognitive testing. And then many of them specialize in psychotherapy modalities, and in this regard, often their psychotherapy training and their psychotherapy specialization tends to be more rigorous and more intensive than what psychiatrists get. So over time, we have seen this differentiation taking place on the clinical side, with psychiatrists being more focused on diagnosis, med management, other medical interventions, and psychologists more focused on neuropsychological testing and different forms of psychotherapy. Now, psychotherapy itself is the name of a treatment modality of what is called talk therapy, and it can take many different forms in many different settings. And psychiatry and psychology are only two disciplines involved in psychotherapy, and not the only two. There are others as well. For example, in the U.S., people who have social work training, a social work background, they often provide psychotherapy as well. And in fact, it is likely more common for social workers to be providing psychotherapy rather than psychiatrists and psychologists in many settings. So it's a confusing, overlapping picture with different disciplines, doing things in an overlapping and shared manner.
And maybe a little bit of that will be a part of some of the like critical questions right around psychiatry that might come up later, because I guess sometimes people want to have a clear kind of idea of the sciences that's almost very idealized and gets at these like objective facts. And I think some of the questions will hopefully bring out some of that stuff.
Yeah, and one thing I'll say is that other medical disciplines are also involved in mental health care at this point, especially primary care or family kind of family practice or general practice, physicians, GPs, because there are not in the grand scheme of things not that many psychiatrists out there that they can see every person who has depression, anxiety problems. Most people with depression and anxiety who are receiving some kind of medication treatment are receiving it in through family practice or through primary care or through their GPs. So that's another complicating factor.
So I wondered, for like, in terms of people understanding psychiatry, if you could give like a brief tour through maybe the origins and like history of the discipline, to give people kind of some idea of the methodological approaches, like why they are what they are. If you think that sort of thing might be relevant to understanding why the discipline is the way it is now.
Yeah, certainly. In general, psychiatry as a medical discipline is relatively young. If you look at it, it begins to emerge as having its own distinct academic identity with a regular presence in medical schools, for example, in the 18th century, especially mid 18th century, kind of in 1850s, 1860s, we see different parts of Europe, especially Germany, develop a physician expertise in this area. And at that time, the general term or name that is being used is alienist. So this group of physicians are called alienists, and at that time, people with severe mental illnesses, they are generally residing in asylums, these large psychiatric institutions. So people there tend to have severe psychotic disorders, then severe manic episodes, severe psychotic depression, as well as at that time, a big percentage of these individuals had kind of various psychiatric problems secondary to infectious illnesses like syphilis. So people had advanced syphilis, and they had neurological complications from that. Many people had severe forms of epilepsy. So it was a mishmash of people with neurological problems, infectious diseases of the nervous system, along with these mental disorders of very severe nature. And alienists of that time were studying, were kind of working with these individuals, doing research on them, trying to treat them. They had very limited treatments available at that time, but they were trying to treat these individuals in these settings. And this remains the case until about kind of when we entered 20th century, early 1900s. And the change that happens at that point is that many problems that are common in the community, such as more severe forms of anxiety and kind of certain milder forms of depression. They start being recognized as medical issues, and they're being addressed through a wide variety of frameworks. So, for example, in primary care settings, we have this concept of neurasthenia, of people with kind of having a vague nervous energy problems, and they're being treated. And then the early psychotherapists are emerging through the influence of Freud. So Freud kind of is very active in the early part of the 20th century, and he's developing his psychodynamic ideas. And so and Freud himself was a neurologist by training. He was not a psychiatrist or an analyst, but due to his influence, we have a group of clinicians who are seeing patients in the outpatient setting, in clinical settings in the community. And slowly, as 20th century progresses, these two streams get combined. So the group that was devoted to seeing patients admitted in asylums starts merging with the group of people who are seeing these milder problems in the community as well. And I would say, by the time the Second World War happens, and in the years after that, that consolidation has become more formal, and we see psychiatry emerge as this discipline that is dealing with behavioral problem difficulties across the board. Now, one thing to note at this point is that in the first half of the 20th century, psychiatry or medicine is the main game in town when it comes to clinical treatment of these conditions. Psychologists at that time they're involved on the research side, but they are not clinicians generally for the most part. And so everyone who is getting some kind of clinical treatment for that is being seen by physicians and being treated by physicians. It's in the second half of the 20th century that, as the number of people with these problems who are seeking help grows, it becomes clear that the medical profession alone cannot address all of these people. And also we see psychology as a discipline start developing more psychotherapy treatments and more kind of specialize in that regard. And we see the emergence of psychologists as clinical treatment individuals. And we also see emergence of other disciplines like social work and jump in. The situation becomes more multidisciplinary in the second half of the 20th century, and before that, it was primarily medicine as being the only game in town.
Awesome. So I was wondering then, I mean, in some of your explanations, and I guess in a lot of these different approaches to studying the mind as well, there's sort of, I mean, it's difficult to even ask the question without sort of begging the question in favor of a certain point of view here. But, there's certain ways of, I suppose, taxonomizing things that people see as problematic about the mind, right? So, you hear words like normal or abnormal, disordered, or even illness, right, being used. And I wondered if you could talk about, like, what have these terms meant historically, and what do they mean now when they're kind of deployed by contemporary psychiatrists?
Yeah. So these are very loaded and controversial concepts and judgments. I would say that in the early early years of the profession, certainly for much of 18th, 19th centuries, and even kind of until the first half of the 20th century, there was not a lot of self-reflection in the profession regarding what is the concept of normality that is being used, or how are these judgments of abnormality being made. And part of the reason for that was that the profession was dealing with behaviors that were clearly very extreme and clearly very disturbed. So remember, psychiatrists at that time are working mostly in asylums, and a person has to be severely disturbed that they are removed from the usual day-to-day, the living situation, and sent into the asylum. So people are having extreme psychotic states where uncontrolled hallucinations and delusions and paranoia, or they're so severely depressed that their bodies have slowed down, they're barely eating, they might be catatonic. So when we're dealing with these extremes of behavior that that seem something has gone wrong, it seems rather obvious in those kind of situations. So there was less inclination to wonder as to like how exactly are these abnormal, or why are we calling these abnormal. But as the scope of the profession expands, and we see more and more milder problems in becoming part of the diagnostic schema and classification as well, and people start seeking help for milder problems, depression, anxiety, other things, then the line becomes more fuzzy, and we have to kind of we have to be careful about how it is, what it is, that where are we drawing the line between this is where norm, quote unquote, normal is ending and some kind of problem again. Another thing that has been a huge that has strongly influenced the debate is the history of homosexuality as a psychiatric disorder. So for most of its history, homosexuality, along with other sexual orientations, were by default seen as pathological. So it was just assumed that kind of non-heterosexuality, was an abnormal, pathological state. In the 60s, we see the emergence of the gay rights movement, and at that point, social attitudes have begun to change. People are becoming more permissive and more tolerant of differences, sexual orientation. But officially, homosexuality is still classified as a psychiatric disorder in the U.S. in the DSM at that time. So the gay community starts protesting against psychiatrists, started saying that it's wrong that homosexuality is classified as a disorder. Why are we doing that, etc. And this leads to a fierce debate within the profession, and the whole history is actually quite interesting. But by early 1970s, it was, if I remember correctly, it was in 1973 that American Psychiatric Association makes a formal decision to remove homosexuality from DSM-2 at that time. It declassifies that. And the official rationale that is given at that time is the recognition that many people with homosexual orientation, they are able to function fine within society if they're not discriminated against. They're not distressed by being homosexuals. They're not disabled by being homosexual, and by all accounts, they can live pretty happy, productive lives if they can do so. So that leads to a formalization of a definition of mental disorder for the first time in 1980 with the third edition of the DSM, and with distress and disability being used as one of the criterions. So there's a general kind of consensus that it's not enough to say that the condition is abnormal in some sense. There needs to be some kind of a genuine negative impact on life. The person has to either cause the condition has to cause severe distress, it has to impair the person, or it must be really disruptive to the person around them. And if that is not the case, then psychiatry and medicine should stay away from that and not try to pathologize that. So distress and disability become one of the criteria. Then the criteria is that they still, the profession holds on to a notion of dysfunction, but that notion is fuzzy and not very clearly defined. And the way it is utilized in diagnostic manuals like DSM and ICD is that it is still referring to our ordinary, commonsensical folk psychological idea that something is out of what we expect in our day-to-day circumstances. So the depression, for example, or anxiety that someone is experiencing, the distress someone is experiencing is out of proportion to the situation, or it is excessive by our everyday standards, or that it doesn't follow our usual norms of rationality, for example, in the forms of delusions, or that it doesn't retain normal internal meaningful or rational links, for example in the case of obsessions or compulsions. So these are still folk psychological kind of judgments. So these are not biostatistical judgments. They're not based on, for example, 2 standard deviations from the norm. These are not biostatistical judgments. These are not evolutionary judgments. They're not saying that, oh, they're certain brain mechanisms are naturally selected, and if a certain mechanism fails, then right. So these are not biostatistical. These are not evolutionary. These are ordinary folk psychological, commonsensical kind of judgments. And the reason we are still relying on them is because we haven't found a good enough substitute. People have been trying to see if we can provide some other kind of basis for the notion of a mental disorder, but such efforts have not been clinically successful. So right now we have this kind of somewhat uncomfortable situation that we are relying on one hand on these folk psychological judgments of something having gone wrong by our ordinary social cultural standards, but we are becoming mindful that this is an ethically problematic area, and so we need some kind of safeguard. And the safeguard that we are relying on is that by asking that it needs to be a genuine problem for the person, and we should not be treating something just because of social prejudice or just because the society wants it to be treated.
Yeah, so in terms of what you're saying there, definitely there's like a reassuring aspect to it, right? Like it seems like there was maybe an improvement on ways of thinking about things that was somewhat like naive and would lead to like harmful kind of outcomes in various ways. I guess the problem is, as you expressed, those criteria don't seem sufficient to maybe justify the values we have that are at play in kind of what we might consider like good psychiatric practice, right? Because as you were talking, I don't know if you have many of these sorts of conversations, but I have a lot of conversations with people where, for example, they might come from like a Thomistic background or something. And so in terms of how they would think about harm or how they would think about like things like function, right? They might have this metaphysics of like Aristotelian teleology and or a theology that includes things like sin. And there's like a value disagreement or even a metaphysical dispute where, obviously I would like evaluate something like homosexuality or like really, contemporaries like the kind of trans healthcare discussion, right? And I'd think about that from a certain point of view, but they're sort of, I guess, entirely consistent with themselves and even the criteria being put forward, in that they might say, well, this violates some notion of like proper function or, like the ends of someone's essence, as it were, or something like that. And I wonder, do you think that psychiatry sort of has within itself the theoretical means to like push back against that sort of stuff, or is it really almost a lucky historic contingency that our values have happened to be where they are on these sorts of issues?
No, it's these are certainly very very messy and challenging questions, and this whole debate has been philosophically quite intense. One of the big areas that gets talked about in philosophy of psychiatry, but there also has been quite a bit of debate within the psychiatric profession too. So and different people bring different kind of intuitions and different kind of preconceptions to this debate. Now there's a group of people who feel that if we are going to call something a medical problem, or if we are going to call something a medical disorder or a condition, then the bar needs to be more stringent, and the bar needs to be pretty high. So they would argue that we need some kind of a clear evidence that a mechanism has broken down, or a mechanism is failed to doing what it is supposed to be doing in some sense of biological design. So the two approaches that tend to be most commonly invoked, there's the evolutionary approach, and Jerome Wakefield is someone who has been a proponent and advocate of that. And the basic idea is that we figure out the evolution, how evolution has shaped behavioral functions and mental functions and brain functions related to that, and we determine situations where behaviors are reflective of mechanism failures, where those evolutionary evolved mechanisms have broken down. And so if someone is having, let's say, anxiety, severe state of anxiety, but that is simply because that's how that's how they were designed by evolution. So there's no mechanism failure, but they're simply in a situation where they have been naturally selected to be really anxious. Then people like Wakefield would say that these conditions are not disorders because there's no evolutionary failure. Um, and then there are kind of other people like Christopher Boers who try to think of it from a more biostatistical standpoint, and they say that we have to look at what are the species typical norms. What kind of functioning is typical for a certain member of a species of a certain age and sex, and if a person's functioning deviates from that species typical norm too much, then that should be considered a disorder, but only if we have evidence of that kind of thing. The challenge kind of here, the reasons why these kind of approaches have floundered is that a lot of problems that people bring to the clinic for which people are seeking help don't meet these criteria, and those problems are significant. They're significant enough, they're distressing enough, they're disabling enough, and we have treatments that help them. So, for example, and in many cases, our understanding of the evolutionary history is very limited. We don't quite understand, how these different mental functions have evolved. And if we don't understand the evolutionary history very well, it's difficult to say, what kind of failure has taken place. So, for example, take someone who comes in with panic attacks. So they're having repeated, frequent panic attacks, and they come in to get help. Now, because anxiety is an evolved function, some people through biological variation are going to be predisposed to having high anxiety states which could result in panic attacks. So is panic disorder, or is any given person with panic attacks experiencing some kind of breakdown of an evolved mechanism? We don't know, but we have that person is clearly suffering, they want help, and we have medications and psychotherapies that can help them. So should we not treat them because of these abstract concerns about evolutionary function, right? So in the clinical setting, those biostatistical and evolutionary concerns often become remote and become abstract, and what the clinicians end up focusing on are the problems in front of them. So the way I think of it is that I think we have to recognize what it is that we are doing. A condition or a person is presenting in a medical setting, in a clinical psychological setting or a medical setting, because they have a problem, and we can conceptualize that problem as being a medical problem if we have the tools to evaluate that condition medically, and if we have the tools to address that condition in some way through medical interventions. I think that this kind of approach reflects what happens in actual clinical practice too. However, I think this is a crucial part, is that we have to recognize that there are many different reasons why certain conditions show up as being a problem, and sometimes conditions show up as being a problem because of value disagreements in society, or because of social discriminatory processes, or simply because our collective understanding of those conditions is poor. And so that is where the ethical problem comes in, that conditions can emerge as problems because of social prejudice or because of social discrimination. Homosexuality is a good classic example, but we are seeing these recent debates around autism, for example. So especially people with more autism of the more higher functioning variety, if they are provided the right kind of social support, and if they're provided the right kind of social environment that accepts their different neurocognitive differences, they can flourish, they can be very they can remain very, very well. And so in those conditions, the assumption that the difference in neurocognitive style should be treated as a pathology becomes questionable, right? And so so what we need is that we need some kind of transparent process where stakeholders can have discussions about why is it that a certain problem is emerging as a problem, and to the extent that things are becoming a problem due to lack of social accommodation or social discrimination, then addressing those is the better solution rather than trying to medically intervene on the person. So, in my view, this is a problem of value disagreements that is best resolved at the level of the values through transparent discussion between stakeholders.
Yeah, so I've got a question that I think sort of follows on from some of the things that you've been saying, and I think there's a way of looking at the mental or psychiatric problems that people have, that sort of looks more at the systems that they're in, or even thinks of things as like political or economic problems. Obviously there's an impact between things like wealth inequality or people's ability to afford like homes and things like that, and their ability to have like gainful employment, and that like mental health. And I wonder, I mean, there'll be an aspect of this that's your professional opinion, and maybe an aspect of this that's your personal opinion. To what extent you think that psychiatric conditions are sometimes normal responses to sort of like bad social or political arrangements. And I guess even if they were, would that delegitimize the diagnosis in psychiatry at all, or do anything for it?
Yeah, I think the part of the challenge with with discussions like these is recognizing that we don't have a coherent scientific account of what constitutes as normal. Kind of normal in what sense? And so the many mental health problems certainly are understandable within the larger social context. They are certainly expected. They can be expected to occur within a certain context. um, and these would range from normal to abnormal based on our ordinary folk psychological judgments. Again, and we are relying on these kind of folk psychological judgments because we don't necessarily have better instruments of parsing them out. So for example, if someone is living in poverty, let's say, they financial precarity, housing instability, it would be very normal, quote unquote normal, in social culture sense, for them to be distressed. They would be stressed, they would be anxious, they would be worried, they would be actively anticipating and trying to figure out how to do that. So there would be a certain amount of distress associated with being in that condition. But would we expect someone, for example, who is impoverished and has housing difficulty, other difficulty, to become so depressed that their, for example, body slows down, what we call psychomotor retardation? They can barely get out of bed, they can barely brush their teeth or barely change their clothes, or to a point where, let's say, they start having depression related psychotic symptoms. For example, they start having delusions like their body is decaying or dissolving down, or that they're dying, which in severe depression people can have that. So I'm presenting an extreme range. Now, at what point do we say that this has transitioned from a normal response to adversity to an abnormal response to adversity? Certainly, it is a response to adversity. In some way, it is linked to that. But to what extent it ranges into that kind of range? And at the moment, the thing that we use to draw that line are these, our common judgments of, is this out of proportion? Is this excessive, even according to the person themselves? And are we seeing these rather alarming symptoms like severe psychomotor retardation, severe suicidality, or psychosis? So we are relying on these kind of judgments. So everyone recognizes that there is distress that is socio-culturally normal and expected in a given situation, and then there is distress and impairment that seems to go beyond what we as a as a society would expect in a situation. And the exact boundary of that is fuzzy, and it's not precisely determined because of the the commonsensical kind of nature of this. The challenge here is, I think, that is that we should not misinterpret what we are doing. We should not think that just because something is unusual or abnormal by social cultural standard, it means that there's some kind of a brain abnormality or some kind of brain process has malfunctioned. I think that's the layperson's idea of of a medical problem, that if you say the person has a medical problem, there is some kind of brain abnormality or body physiological abnormality, but that is not what is meant here. And it becomes a problem if we start thinking of all psychiatric problems as being products of brain abnormalities.
Yeah, I guess maybe there's like too much of a generalization in the way I sort of framed this question as well. The angle I guess I'm coming at it from is, and I think I've seen you engage with this book, but I don't know if you've read it, Empire of Normality, which is like a kind of critique of capitalism, I guess, and talking about the intersection of economic incentives with neurodiverse people. And I guess the general form of the critique in that, which I think there's some merit to, seems to be that basically all of the economic incentives that guide the corporate world and people's jobs and how they sustain themselves and have to live are kind of at odds with the way that neurodiverse people flourish and want to exist. And yeah, in the answer that you gave, I guess I'm thinking there's a sense in which you're definitely right to question, like, if you feel extremely depressed in those circumstances as like a neurodiverse person, like in what sense is that like an appropriate response? Is that the question? Or I mean, maybe you would say it is appropriate because like the system is so messed up, whatever, you'd have to give some account of the system, but in some sense I guess it's inappropriate because it doesn't necessarily bring you closer to improving your state of affairs or something like that. Is that the way to think of that particular issue?
Yeah, so I have read Empire of Normality, and so I really love that book, and I interviewed Robert Chapman as part of my Substack series, that's at Psychiatry at the Margin as well, and Robert Chapman is also interviewed in my Oxford University Press book as well. So I'm very well familiar with that line of critique, and I recognize the broad strokes of it. It is certainly the case that our broader socioeconomic, structures and kind of those organization factors, they have a huge influence on people's well-being. And the more exploitative the socioeconomic organization is going to be, the more distress is going to generate, and the more people are going to experience impairment. In that, the reason, for example, why cognitive problems like ADHD, to some extent even autism, have become such a big problem in recent decades is because the nature of labor that that is being asked of individuals is more and more cognitive in nature. So people are expected to mentally keep track of far more things. They're expected to be available, flexible in terms of their work hours. A lot of work involves just kind of staring at screens and typing in email. So versus in earlier centuries and decades, the work was a lot more physical and manual. It involved a lot of physical labor, then it involved a lot of industrial labor, and now we are now the work requires cognitive labors, which means that people who are naturally at the lower end of the spectrum in terms of their attention concentration faculties or cognitive faculties are going to be under more stress and are going to experience more distress and impairment. So distress and impairment is always a function of the individual properties that a person, individual biological, psychological properties, and the demands that they are placed under. And sometimes the collective solution to reducing the stress and impairment is improving the living conditions and improving the work environment, so that the distress, etc., disappears. And so that I agree. And now the issue becomes that these kind of generalizations, this dynamic between individual versus social organizations, applies generally to all of medicine. We across a wide range of medical conditions, especially cardiometabolic ones, so diabetes, hypertension, heart disease, obesity, etc. These are highly linked to social living conditions. So the more financially disadvantaged a person is, the less access they have to good diet, the less access they have to exercise, the more their risk of obesity, the more their risk of diabetes, the more their risk of hypertension, heart disease, etc. And in older days, when infectious diseases used to be much more prevalent in the Western world, things like tuberculosis were linked to socioeconomic status. Lower socioeconomic status had much higher rates of tuberculosis. So it's clear that the general social environment has an impact on physical health, and the worse the socioeconomic environment would be, the worse the physical health would be. But we cannot reduce it and say that it's all just a normal response to socioeconomic conditions, and and we should just only focus on the socioeconomic dimension of that. I mean, clearly that's very important, and that often has an outsized impact on the prevention side of it. So I think what I'm saying is that we have to be mindful of that dynamic. There's a place for individual level intervention, so intervening at the level of an individual who is experiencing distress and experiencing impairment. And then there's a kind of like a more collective level of intervening at the public health level, intervening at the social political level, to improve the general living conditions. And I think both are, in my view, both are essential. And the exact proportion of that is going to vary from person to person, but also condition to condition. And for certain conditions, um, the focusing on the social makes the most sense. So for things like again, sexual orientation, it makes sense to just change social attitudes and be more tolerant of sexuality. I think for many individuals, for example, with gender identity disturbance, the answer is a better change in social attitudes. For people with higher functioning autism, I think a change in societal attitudes is probably the right way to go. But for someone, let's say, with a chronic psychotic disorder, or someone with severe manic episodes, to what extent would change in social attitude relieve their distress and impairment, kind of open to question. So I think we have to, I think, be careful in how we generalize from this dynamic.
Great. So I guess we've sort of touched on some of the things that are in the next question, maybe, but just to taxonomize it and put a bit of history on the bones of some of the discourse around this, what could you briefly outline, like what the anti-psychiatry movement was, and sort of like what it got wrong, I guess, in its time and place, and what aspects of it were correct in your view as well?
Yeah, I've written about the anti-psychiatry movement a fair bit on my Substack blog and in other places as well. And it's hard to characterize it very well, because it's not a single unified thing. And the people involved have come from diverse backgrounds with diverse motivations. And what makes it more challenging is that many of the people we classically associate with the anti-psychiatry movements did not like to be characterized that way. So they themselves rejected the label of being anti-psychiatry. And these days, in many circles, the term anti-psychiatry can be seen as being disparaging or being insulting. So it can be so I hesitate to call someone anti-psychiatry, because I don't know what their relationship to that term is going to be. But in general term, the way people often use the term anti-psychiatry is that they are referring to people who demonstrate some kind of either fierce critiques of mainstream psychiatry as it normally exists, or they demonstrate some kind of bias or hostility towards the profession. And in the classic historic sense, anti-psychiatry emerged as a kind of intellectual movement in the 1960s, and some of the figures typically associated with it include the American psychiatrist Thomas Szasz, who wrote a book in 1961 called The Myth of Mental Illness, basically challenging the idea that there is such a thing as mental illness at all. There was a British psychiatrist, R.D. Laing, and who was famous for his critiques of psychiatry, and his first book was The Divide Itself, and then later on he kind of emphasized the role of family dynamics in creating behavioral problems and the role of general societal dynamics, and he often kind of saw these states of madness as being rich, value-laden state that represented some kind of existential truth. There was the French philosopher and theorist Michel Foucault is often kind of characterized in these terms too. And sometimes Irving Goffman, who is an anthropologist, sociologist, he's characterized. Now, the tricky thing is, one, so Szasz and Laing and Foucault too, they themselves did not characterize them. In fact, they rejected the label. Szasz rejected the anti-psychiatry label. Laing did as well. So all of the main typical figures we associated with that didn't want to be called anti-psychiatry in the classic sense. And another thing that has happened is that unlike the 60s, where these figures are all psychiatrists, philosophers, intellectuals, the sentiment in the 21st century is much more consumer driven or much more service user driven. So the people we see, especially online, who are critical of psychiatry or who are raising concerns about psychiatry or fiercely criticize psychiatry, tend to be people who have had really negative experiences with psychiatric care or mental health care in one form or another. Often they have had involuntary treatment or in hospitalization, etc., or they have had really terrible, reactions with psychiatric medication. So the current, critiques of psychiatry and current negative bias with psychiatry is often driven by these kind of consumer concerns or service user concerns rather than the kind of philosophical intellectual concerns. But the two are highly enmeshed. So so a lot of the so there, like I said, there are two layers of this going on. There's a philosophical layer in which which people are criticizing medical concepts and people are criticizing the rationale for psychiatric treatment, and then there's a more practical emotional level in which people are reacting to the abuses of the system or of abusive system of care, and so they're reacting to a neglect of medication side effects, they're reacting to a neglect of iatrogenic harm, they are reacting to excessive use of force in psychiatric hospitals, and they are reacting to coercive experiences, and I think we have to be a little bit careful in kind of what dimension of it we are tackling and talking about. And and my approach to it has been recognizing that there are many legitimate reasons this kind of critique is taking place. The profession has shortcomings. The track record when it comes to patient safety, when it comes to coercion, has not been the best. So there are genuine problems in practice. There are genuine problems in on the practice side and implementation side, and at the philosophical level, there are genuine questions to be tackled. If, for example, it is true that we don't have an objective criterion for what constitutes abnormality. We don't have an objective criterion for what constitutes psychopathology. These are very value-laden questions. But I think where the kind of the quote unquote the loosely called anti-psychiatry folk go wrong is that I think they end up rejecting medical concepts or psychiatric concepts in some more fundamental sense. They end up saying that if there is no biological abnormality to be detected, then you cannot call something a medical condition or a problem, or that you cannot that if a medication is not correcting a biological deficit, then we should not be using that medication, or the use of that medication is inappropriate, etc. So I think sometimes there are invalid and extreme inferences that people make from these things, but which I think should be recognized and addressed. But I think as the psychiatric profession also need to recognize that there are legitimate reasons why these critiques are taking place in the first place.
Yeah, and I think potentially even within then, just thinking about what you were saying, right? There's probably room for dispute about how expansive that term of like biology is. Does biology mean like function at like the cell level, or does it mean, do you think of the person and their social interactions as like a biological organism?
Yeah, part of the challenge has been, because psychiatry and clinical psychology operate at the mind-body level, and historically we have struggled to articulate mind-body relationship in ways that are not dualistic or not reductionistic. So, finding sophisticated scientific and philosophical ways of talking about behavioral difficulties that don't fall prey to dualism or to reductionism has been a big challenge. And it's even more difficult for lay individuals, who receive medical diagnosis, understand that. And so I I think there are many components of the medical profession and psychiatric profession who have been eager to just promote a very reductive version of what it means to have a mental disorder. That's why we have the chemical imbalance language, and we have the brain disorder language. And I think using that kind of reductive language has backfired, because if people understand these things in these incorrect concrete ways, they're more likely to just reject the entire diagnostic and medical enterprise in reaction to that.
Yeah, I've seen that, I think, in cases where people are trying to like deal with personal issues, and I guess also the political weaponization maybe of medical language, or like so for example, coming back to the trans dispute politically, or like the about what should the status and rights of trans people be. I think sometimes there's because people want to protect trans people, or even like people with different like sexual identities, that there's this desire to find like a scientific fact or something that just comes to us out of the world that will like justify a particular political stance. So it's like, if I have a certain gendered brain or a certain gene that makes me or something like that, then that will like politically legitimize like who I am or something. But realistically, or at least from the value and politics kind of side of things, it almost shouldn't matter, right? Whether or not someone has a particular, you put them in an fMRI machine and you see something in their brain, because if they're expressing like gender dysphoria and they're happier expressing a different way, and that that should be the thing that matters, not this kind of search for an inner essence.
I agree. I think there's a huge, I think, because these behavioral states, I think we still have a lot of older moralistic attitude towards not recognizing the legitimacy of behavioral states as being quote unquote real. So there's this tendency to try to make them more concrete in a biological sense somehow. So saying that, oh, trans identities, because people have some kind of different brain sex than than the one they're born with, or in the case of mental disorder, saying that, oh, there's really some there's a chemical imbalance, or there's some kind of a biological underlying biological dysfunction. It's all an effort to try to make something more biologically real, so that it would be better accepted by society. But because it is it's a misrepresentation of truth in a certain manner of speaking. I mean, there's a grain of truth in it, because all behavior is biologically grounded, but not in this essentialistic manner. So it just ends up exacerbating and further creating more divisions in these issues. So that is a big challenge, and the and our societies have not been not made this process easier. For example, in the U.S., there's tremendous political dysfunction, and the inclination to devote more resources to public health infrastructure is just very minimal. We have not seen substantial progress in that. So when there is this kind of widespread political dysfunction, and you just don't have resources allocated for public health, then individual level interventions become the only thing available, and we end up overutilizing them or overusing them because that's the only option. um, and so part of the problem with over medicalization debate is recognizing that over medicalization is happening because we are not investing in public health in the right kind of way. But the political appetite to invest in public health remains remains very low.
Yeah, and I think with those things too, it can become difficult when people find out that some of the biological sort of stories they might have said to justify a position are not strictly true, or and then the tendency becomes to become like a complete skeptic and distrust all the scientific, and it's really maybe the product of an overly naive sort of view of science and epistemology.
Yeah, and another thing that's going on is that there's a lot of anti-establishment sentiment that has been growing, across. And I think so people in general are more distrustful of authorities of all kinds. So they're more distrustful of political authorities, medical authorities, scientific authorities, and this manifests in psychiatry's case as well, with a general distrust towards psychiatric authorities. But because there is suffering, and because there is a certain degree of resentment, there are also agents in the current information ecosystem that are trying to exploit that resentment for their own ends. So we see this in politics, for example. A lot of people are unhappy with the establishment, and we see these kind of problematic populist movements emerge that try to take advantage of that. And so in a similar kind of way, we have anti-establishment sentiment in healthcare that is recognizing that many people are unhappy and have had negative experiences, and they just cash in on that resentment to serve their own agendas. They have, maybe they want to sell supplements, or maybe they have some other kind of political aims in mind. And so there's that another kind of messy layer of political anti-establishment politics and those things that is going on too.
So, I mean, I did have this as a question, sort of like your views on how psychiatry as an institution can kind of address these issues of trust between the profession and the public. I mean, I don't know what your views would be. Is it more public science communication that's needed? Maybe there's a core of like legitimacy to some of the grievances people have. I mean, what are your thoughts on improving that?
Yeah, I mean, and I think that I think the first thing medicine has to recognize are the reasons why such a loss of trust has taken place. I think the impression that scientific institutions and medical institutions try to give to the public of the scientific method is has been problematic. So a layperson's idea of how science operates, it's very disconnected from the messy manner in which actual science operates. And what happened recently during the pandemic was that what used to happen behind closed doors, the uncertainties and the messy decisions that scientists had to make, they became much more visible, and people started seeing scientific results coming out in kind of like as they're coming, preprints coming out, the scientific debates that are happening, and so the uncertainty that was previously hidden from them suddenly became apparent and suddenly became open. And for people who had an idealized idea of science as representing some kind of shiny truth, it became tarnished, and they reacted very negatively to it. So I think first we have to convey a more realistic idea of how medicine and science actually operate, and the kind of uncertainty that is involved in these decisions. Any recommendation that comes from medical institutions, it is not infallible. It is operating with a certain degree of uncertainty with regards to evidence, and being clear about what that uncertainty is, so that people know. I think being transparent about the relevant kinds of uncertainties is very important. So uncertainty around diagnostic validity. So instead of just confidently saying that here we have these psychiatric diagnoses, and if you meet these criteria, you have the diagnosis, openly acknowledging what is the basis on which these diagnoses are made? What are the uncertainties? What are the value disagreements? What are the situations in which diagnosis may be uncertain and diagnosis may change, that they don't represent discrete biological abnormalities in the same sense as neurological disorders. So being transparent, open about that, allowing discussion, and then I think being open about the iatrogenic harms and risks that come with treatments. That medical treatments are not benign. They sometimes have serious side effects, and sometimes they can be long lasting or protracted. And devoting research funding and resources to try to better understand those side effects is very important too. Because what has happened is that we have developed new medications and treatments over time, but we have not sufficiently dedicated enough resources to try to understand their long-term risks and to try to better understand the rare side effects or uncommon side effects that happen. And so that needs to be a research priority as well. And then when it comes to issues of involuntary treatment, I think there needs to be more transparency and more responsibility, with the profession being open about what are the circumstances under which people are being involuntarily treated against their wills. What are the conditions under which that is happening, and what kind of outcomes are taking place. So there needs to be a certain degree of public accountability with regards to involuntary treatment and other aspects of treatment as well.
Yeah, from the philosophy of science side of what you were talking about there's a philosopher whose work I've really enjoyed called Hasok Chang, and he sort of, one of the ways he motivates his project, he kind of says that there's this kind of conventional division in the discourse of philosophy of science between the so-called like realists and anti-realists, and obviously like with the anti-psychiatry, that's sort of an overgeneralization and everything, but a point he makes that I think he's very correct about is often the realists are kind of have the most unrealistic view of what's going on when people do science, and that can be very disheartening to people maybe as they witness the kind of you want a more robust, sort of messy human account of what's going on, and then maybe you can more accurately understand both the power of what science can do and also the realistic drawbacks and things.
Yeah, I agree, and I love Hasok Chang's work. He's, I think, one of the more, provocative, influential, philosophers of science who has done really wonderful work, and so I admire him myself.
Great. Well, I really appreciate your time and you coming on. Is there anywhere then that you want to redirect people to if they want to come across more of your work, or anything that's upcoming for people to look out for from you?
So yeah, I think my Substack is probably the best place to follow my kind of more public facing and quasi academic writing. So it's Psychiatry at the Margins is the name, and www.psychiatrymargins.com. I'm also present on social media, so X, formerly Twitter, Blue Sky. I'm there as well. And then you mentioned the Oxford University Press, that book that came out last year, Conversations in Critical Psychiatry, and that's a reasonable one too. For more kind of academically oriented folks, there's a psychiatric journal called World Psychiatry, and I was a senior author on a paper on philosophy of psychiatry that we published there last year, and it was a broad, informative review aimed at clinicians. So clinical psychiatrists and psychologists, about learning what are some of the current discussions that are taking place in philosophy of psychiatry and how they relate to clinical practice. So I would refer people to that paper. And there was another paper last year on psychiatric diagnosis, a clinical guide to diagnostic pluralism, which goes into some of these philosophical and scientific debates around psychiatric diagnosis and how to better understand them. That's another useful resource for academically oriented folks.
Awesome, great. So I've got most of those links in the description as well. So if people open that up, they can click on those and go there. Obviously, if you think that this is useful for a psychiatrist in your life, feel free to share this discussion with them as well and prompt them onto all those links and things. But yeah, other than that, thanks for watching, everyone. Thanks for coming on. I'll end the stream there.